Hi, Dr. ManSingh.
Hi,
Hi, I'm Summer. Nice to meet you.
nice meeting you too.
Thanks for being here. I am going to go ahead and give you co-host capabilities so that you can play around and maybe test out your slideshow.
Okay, let's see. I'm using Google Slides, so share screen, and you can see it.
Yes, perfect.
Okay, and how do I get to the next slide?
I think
Okay,
you can, yeah,
yeah,
just
the arrow keys are my earlier best way. So yeah,
and then I'm not sure if Dr. Luker or I think Dr. Maxim will be here. And she will facilitate the chat. Are you okay with being interrupted if the question comes up in a moment that pertains to what you're
I
speaking?
think so. Yeah, that should be fine.
Sounds good. And then I'm gonna actually have you stop share for now.
Okay,
I'm going to share our have the opening slides at the beginning and then I'll hand it over to you.
got it.
And then we have a lot of time if you want to run to the restroom or get water, you can do that too.
Okay, yep, I will quickly do that.
Thank you.
I made it.
Hi. Oh, are you back already?
I am back.
Wow.
Hi. It's
Hi.
so good to see you. Oh my gosh. I'm sorry to be joining so late. I literally got into like a fender bender on the way
Oh my
back.
No.
And thankfully like it's nothing bad. Everyone's fine. Nothing's really damaged, but so we were able to literally just shake hands and move on.
that's not.
I would have had to wake up Maya.
Oh my gosh.
Are you guys all ready?
Are you in Omaha?
I am.
Wow.
What time is it?
It's 5, so not bad. In fact, it let me finish the days. Yeah.
Oh, that's interesting. I would not have guessed 5 hours. I'm very bad at American geography.
It's probably the furthest away from. I mean, I'm sure people from your class are further away, but from my class, I moved further than the others.
That's true. My class was a lot of people that moved from far.
Yeah.
Yeah.
I'm trying to come back.
I hope so. Please come back. When are you done?
2 more years.
2 more years.
Yep.
Oh,
At this point, they still need cardiologists.
they definitely still need cardiologists. I'm pretty sure when you're done in 2 years, we'll still be needing cardiologists.
Yeah. And then Polly can come the year after me.
Exactly. I'm very excited for so many residents going into fellowship who are interested in coming back to Hawaii to work as well.
Yeah.
That's really, really good. We really need all the specialists.
Yeah.
Hopefully someone from neurology will want to come back as well.
I thought they're getting a few. Well, Yui is doing neurodevelopment and she won't mind coming back.
That's true. That's very true. I forget, someone did go into neurology as well, though.
I know someone did a long time ago. Recently, no one in 3 generations above or below me.
Really? Okay, yes, it was in the year above me. That's the last person who did neurology. And he went back to, no, I think he's still on the mainland. He didn't go back to Japan. I've just been kind of chattering away as people are joining. I can slowly start getting a little bit more into our official portion of pediatric echo. So we can
go through the intro slides.
Go through the intro slides and then let a few other people join, and then we'll do our introduction and get started. Perfect.
Sounds good. Thank you, Dr. Luker. Hi, everyone. Happy Wednesday. Thank you for being here at Pediatric Echo Hawaii. I'm Summer. I'm the coordinator here, and we have Dr. Luker as our director and Dr. ManSingh today. Just going through some of our intro slides. Pediatric Echo offers MOC Part 2 credits. Please have your evaluation surveys in by next Monday, 2 p.m. if you want to receive this credit. Dr. ManSingh's general objectives for today is to be able to recognize common causes of sudden cardiac death in the young, perform appropriate history exam and initial testing for sudden cardiac death, identify basic clinical features of Marfan syndrome, and understand common inherited arrhythmias. Did I do good deciphering your handwriting, Dr. ManSingh?
You did. I was sure I'd have to type it out.
We're happy to offer CME for physicians for today's session, for pediatric echo, for nurses as well, and social workers. We do not have any conflicts of interest to disclose. And following our session today, you will receive 2 emails to receive your CEUs if you are wanting to earn them. One will be the link to the evaluation form, and the second will contain your password, which is lowercase PEDS. And I will hand it over to Dr. Luker to do our formal introduction for our guest speaker today.
Thank you so much. Yeah, moving right on. I am extra excited today, I have to say, to introduce Dr. ManSingh, who graduated from our residency program last year. I can't believe it was really just a little bit over a year ago. It feels like forever already. He has moved on to Pediatric Cardiology Fellowship and is therefore going to be giving us this excellent overview. I will be available as always in the chat. If you have any questions, I'm happy to pass them on. And you can, of course, always unmute yourself and feel free to add any questions, patient cases you have, etc. And then I will hand it right over to our presenter.
Yeah. Thanks, Dr. Luca. I'll just get this shared. But yep, I'm excited to be back. Dr. Luca was my faculty advisor for residency. And it was a great 3 years. So yep, when she reached out, my first response was, I was just so happy to hear from her. And then I'm like, yeah, sure. I think she cultivated that I love teaching. She cultivated a little bit of that in me. And so I'm taking my opportunities whenever I can. Now I'm a second year fellow, just starting second year. As she said, time is flying, but it's exciting. I'm learning a lot, and I'm going to be going over family history of sudden cardiac death, which I found is a tricky subject to read up on and find out, but as cardiologists, we often get patients who have that. And as pediatricians or people caring for children, you will often get questions about those. And just knowing what to answer even before they see us is pretty important. I have no financial disclosures. Most fellows don't often have that. And I just give a case. This is slightly exaggerated, but I have seen similar stuff. But one of your 16-year-old patients recently lost her father, who was 48 last month. He came home from work complaining of chest pain, suddenly collapsed. He was rushed to the ER where they sent him for triple bypass, but he did not survive the surgery. The girl's been in shock ever since. She was close to her father, even though he used to drink and smoke a lot. She does feel her heart rate fast, even more since her father passed away. And she could distract herself by playing basketball. That time, she feels no symptoms. And she's on the school basketball team and is much more athletic than her father, who weighed 300 pounds. So, again, I've got similar cases where they've, children have lost their parents early. It is shocking. I've kind of nudged things around a little bit. I've given a lot of extra history, which we'll have to get, you won't get initially. But what I'm trying to get here is not all patients will have, I think she still gets a little bit more workup, but I think the cause of the father's death was very lifestyle related. And I don't think in this case, she's at increased risk of cardiac death herself. The more common, or I would say another very common referral we get is basically you have the pediatric forms and you've got options saying, has anyone in your family died below the age of 55? And they take it and then we don't know what to do with them. And that's probably more common than this scenario. So just going over what we're talking about, we'll talk about incidents of sudden and early cardiac death. So I've kind of used those two. They're not interchangeable, and I'll talk about both of them. Sudden cardiac death is it's a little better defined. Then initial steps and role of the PCP or the first provider who's interacting with them when they either reveal it to you or whether it's on a form. History, exam, initial testing, especially in your office, and then the familial diseases associated with specific causes of sudden cardiac death. So I'll say, just based on this outline, these, it's a little unevenly divided where a lot of the talk will be focused on that last line because you want to know what to look for. The other thing which is interesting here is we're actually thinking, and which we don't do a lot about in pediatrics, we're thinking about adult medicine because we're actually trying to diagnose or figure out what happened to the the family member or relative and think, can the same thing apply to the child? So some of the causes of sudden cardiac death absolutely overlap, and some of them they're less likely, like myocardial infarction. So, and in fact, I did say one of the objectives is common cause of sudden cardiac death, but if I was to go into detail about those, it would be a whole extra talk. I think to simplify it, what we're trying to do is figure out the risk of a child having an adverse event when a family member's had it. I think that's our main goal here. So talk about sudden cardiac death. It's around 2.3 to 7.5 per 100,000 patient years in the 1 to 40 age group. So that's around 1,000 people a day. When it comes to below 18, around 3,000, there are 3,000 to 5,000 incidents a year. When I looked for statistics for Hawaii, I couldn't find pediatric sudden cardiac death in Hawaii. If you extrapolate, there would be 3 to 5. Overall sudden cardiac death is around 1,000 to 1,100, again, in a year. And sudden unexplained death is when autopsy and toxicology do not identify cause of death. A majority of these, and again, it's some of these are never definitive, but they attribute it to cardiac causes. And as we'll go over later, a major cardiac cause here is an arrhythmia, because those have no structural changes, there's no signs, you won't have any labs, and those are what it can be attributed to. The reason to screen families after sudden cardiac death, especially at a young age, is depending on the studies, anywhere between 15 to 22% of families have had a heritable cardiac disease. And again, we're going to be talking about which diseases you're going to see out of those. And this is more going into early cardiac death, which isn't defined as clearly. The question, meaning people have asked, is how early are you calling it too early for someone to have passed away from cardiac causes? Several screening questionnaires, and again, I'm not sure what's used in every office, but my clinic office in residency was 55. So are some of the referrals I get here. The studies which look into sudden cardiac death is looking at young age sudden cardiac death. They usually specify 50. Interestingly, like the previous study I was referring to in the previous slide was 40. So the statistics are all over the place. And coronary artery disease, especially even in that 36 to 49 age group, it's usually non-inheritable coronary artery disease. So I'm not talking about familial hypercholesterolemia, it's just coronary artery disease due to risk factors. So again, if with a death in that age group, it doesn't necessarily mean there's something heritable. And that's why I say one thing I'm going to drive home is that the history and the cause of death are more likely to determine the extent of workup rather than just the age of the event. For example, that case I gave, it was 48, but it may have been myocardial infarction, and you may want to do basic lipid screening, but you don't need to go extensive, do an echo, restrict from activities, all of that. In comparison, if there's a 51-year-old with known, let's say, signs of Marfan syndrome, which again, I'm going to talk about, and then has an aortic dissection and didn't smoke, had normal blood pressures, you will want to work up that family more. But again, in all, whether it's a heritable cause or inherited or acquired, it's all progressive. I like to joke, the day I turned 30, I got back pain, but there's no cutoff number. It's insults adding over the course of your life to any part of your body, including the heart. But so this is more in the acute setting, more, when family is revealing to you, if they're close, you're their primary caregiver, not just a tick on the form. But it is a traumatic event, and especially for young children, and depending on the age and the development, they process it differently. And your priority should be given to social support, counseling, and grief management. The chances that the child is at immediate risk is very low. It may not want to be the thing on their mind, Of course, some of them will be thinking, can this happen to me? But a lot of them are just dealing with the grief at that point. So you don't need to urgently be probing into questions, getting a full history, referring, because at this point, that may not be the priority. Again, when they bring it up, a lot of these patients, and even though I'm giving good first steps, I do anticipate a lot of these patients are ultimately referred to cardiology. But again, it doesn't have to be done immediately. It's when the family is willing to talk about it, or has questions of their own. And sometimes, especially on the forms, you hear about, a distant aunt or maybe even grandparents died young, but it should always be first degree relatives who are evaluated first. So if it was an uncle or let's say a cousin who died young, it's their parents or their siblings who should be evaluated first. And that's just because a lot of these are autosomal dominant, they don't skip a generation. And so if the parents or the first degree relatives don't have it, you're just missing out a few. You can probably save evaluating further people. And the other side of things is sometimes you can pick up incidental findings or different findings on second or third degree relatives, and it may distract you from something else that's going on in the first degree relatives. But why again I'm focusing on this big, I just said in the previous slide, most of these patients are going to end up seeing cardiology at some point or other. So why does it matter? But it is really important, I think, understanding as a primary provider, because you're going to answer the question, could this happen to me? And if someone starts thinking about it, it's not getting out of their head quickly. And assuming there's still long wait times for, meaning it's across the country to see a specialist, you're helping them deal with, save those 2-3 months of anxiety, thoughts in their head. You can absolutely perform an initial workup, which you're going to go over, and that could help reassure the family. Then you can also risk stratify this. If there was a clear hypertrophic cardiomyopathy and talking to the family, you're seeing some signs in a kid, you could call up cardiology instead of just making that fax referral and say, hey, this is quicker. And there are rare cases, like again, going back to the myocardial infarction, where if you're comfortable, you could actually save them the cost of a cardiology referral and echo, travel to another island for some families. And you can make decisions on sports participation. This is something, if you read a cardiology note, we'll always say, are the exercise restricted or not? And I'll add over here, if you're uncomfortable, it is okay to stop, hold sports until we've evaluated them. But at sometimes, again, the reason I gave that exaggerated case, which kind of just drove in the points where that child is at low risk, especially sports were important to her, you could let her continue playing. So I think it has both of those. You can hold on sports till then or continue it, which is important because, as I said, again, it's 2 or 3 months and families will ask. See some. Okay, so just going into the history, and this is where I said this is different. It's one of the more unique histories I've taken because, again, you're trying to figure out what happened to not to the kid who we're so used to treating, but what happened to that family member. So you're obtaining a past history of the family member, you're presenting symptoms, surgical intervention. I'm just gonna silence it. Yeah, surgical interventions. That's one thing I've often asked is, what kind of surgery did they go into? And that's why I included that in the first slide, did they have a bypass? Because again, bypass makes me think coronary artery issues, which makes me think not necessarily inheritable. You go into what their lifestyle was like, morphological features, and if they had any genetic diagnoses. Family history, at least 3 generations, seeing if if there's any other thing which people may have glossed over or didn't think was very important. And then you can probably ascertain the cause if you can. If that family member, did they know what happened? Some families don't. Sometimes you can confidently say this was an MI or an arrhythmia or a dissection. And sometimes it's a lot more vague, and in which case, again, I think they are going to get referred to cardiology, but autopsy reports are useful when they're available. Again, because our aim is to figure out if they have the same risk. And just going back to another point I mentioned earlier, and this is why I've talked about that it's not urgent and priority should be on counseling and all, because if someone passed recently, you don't need to rush talk about, hey, were they a smoker, were they a drinker? That may not be what they want to talk about immediately. And again, that is why there is a timing to these things, and it doesn't have to be right away. But when they're ready to talk about it, this is all valuable information. Normally, when they've come to cardiology, they are ready to talk about it. And so these are all the questions I'm probing. Yeah. Physical exam, and again, I won't go over a complete physical exam. Things that really help are blood pressure measurements in muffins, things that put you for dissection. Higher blood pressures can be a problem. In dissection, you can have a different, coarctation as well. You'll have differences across the limbs. Stigmata of Marfan syndrome, I'm going to go over that in a little bit. And again, skin findings, rashes, things that may put them to risk, may ascertain to a genetic diagnosis. Then, of course, a heart murmur. And I think it's a whole separate talk about what's a pathologic heart murmur and what's a benign. That's probably even more common referral, but I'll go over when we talk about case by case what murmurs you're listening for. And femoral pulses, that again goes to the blood pressure measurement, where you'll have weaker femoral pulses with dissection, coarctation, a few other conditions. Again, this is not absolutely diagnosis. It's a screening thing, and it could tell you if you're worried about something. Initial testing, and ECG is an appropriate first test. It's cheap. It's cheaper than a cardiology visit. It can give you, if it was an arrhythmia, if it was long QT, if it was Brugada, things like those, it can give you the diagnosis right away. Even with hypertrophic cardiomyopathy, it can give you a lot of hints. And while a negative ECG doesn't mean they're home free, it can be really reassuring. And that could be, in fact, it could be a major decision maker between things like exercise restricting again, which, as I've said, the cardiologist will take the final call on, but I will say most of the conditions where you would exercise restrict will have an abnormal ECG. So that it does really help. And echo can be done on a case-by-case basis. It can even be done, you can refer to the cardiologist and they'll do it with their visit. I'll talk about some of the cases where we're almost always going to get an echo, so it doesn't hurt getting it earlier, especially if you can get the echo quicker to a cardiology visit. But the reason I don't want to prioritize or encourage ordering echoes for everyone other than availability is it's a lot more expensive than a cardiologist visit. So we're going to talk about a few things where I can almost guarantee you the cardiologist will order an echo. That doesn't hurt. It'll give you answers. You can talk to the family about it if you're comfortable. But if it's vague, if it's not clear, and the cardiologist won't order it, it's just saving the family money. I've added a few more, but I don't think these are things that'll be ordered at a primary level. And that's cardiac MRI, exercise testing, and genetic testing. And I'm not going to talk about these in detail because these are things the cardiologist will order. They're much more expensive, and we don't want to, again, spend resources. I've got a comment in the chat. Yep. And yeah, so there was an example of Pistol Pete who died suddenly. And yes, sometimes you're absolutely not sure. Again, it may be very difficult to ascertain. I'll go off from here. One sign that it's bad, or meaning is dangerous, is if you die in the middle of sports, not after, not at rest, but in the middle of sports activity. That is pretty likely a cardiac illness. And I would say family members should be screened by a cardiologist. And again, after this talk, I don't anticipate you to be able to risk stratify every family or diagnose everything, but I want you to be, at least in some scenarios, like the case I gave you, be able to reassure some families. And also, if it was a case like Pistol Pete, redirect the families to us on a quicker basis. And just to add, you can interrupt at any point. I'm happy to segue. But so going into the second half of the talk, which is causes of sudden cardiac death. And again, these are what I'm going to be doing is talk about the cause in the family member and going into what things you should be looking for in your patient. So myocardial infarction, and the 5 major risk factors are hypercholesterolemia, high LDL, low HDL, some form of glucose intolerance, and smoking. And over 90% of these events happen at least one major risk factor. There's several minor risk factors, age, OCPs, and all of those, but over 90% have at least one of the above. If you think about MI in children, and this is below 18, your first thought is Kawasaki disease. And in fact, in the ER, they've said the one question you need to ask, especially in Hawaii, which is more than anywhere else in the country, is if they've had Kawasaki disease. Yeah. So, but that's the one thing. And again, Kawasaki disease is not, there is a 2% risk, as Dr. Melish has taught me, but it's not necessarily inheritable. So again, if there's a child in the family who had Kawasaki disease and unfortunately had an MI, it doesn't mean the others are at increased risk if they didn't have Kawasaki disease. Another thing with myocardial infarction in young people, when you're worried about if family members can get it, is smoking is a risk factor in 65 to 90%. And so at a young age, your risk factor, even if you have other ones, smoking is the one which often is correlated. And medications, OCPs in the setting of smoking, and cocaine, those are the causes you'll see in your teenagers or younger age, you'll see myocardial infarction. But again, what I'm trying to segue into is if someone in the family has had a myocardial infarction, what are you worried about in the child? And the only thing which would put the child at an increased hereditary risk is familial hypercholesterolemia. I shouldn't say only, but that's the main one. Of course, if they've got a hypercoagulability thing, which those are other risk factors, but that is the main one if there's a history of early cardiac death due to a myocardial infarction, and you don't find some of the other obvious causes. Familial hypercholesterolemia, it's a lab result. You get elevated LDL triglycerides, but you can have xanthomas, both near the eyelids and the Achilles tendon. I will say again, I've never seen any of these, but these are what you are looking for in your child, just as an added risk factor. But if you're concerned, a family member had a heart attack, you're not seeing these signs, or even if you are, the quickest thing is lipid screening. That's what, when I see families who give me a history of, I'm sure it was a myocardial infarction, I often don't do a lot of testing for them. The only testing I do is lipid screening. And sometimes I ask the pediatrician to do that. And I know their insurance treats things differently. Sometimes they refuse. But these are the guidelines for the AAP and AHA, that at 9 to 11 and then 18 to 21, you do lipid screening. If there is a positive cardiac history, like any early myocardial infarction, you screen at 2 to 8 years and 12 to 16 years. You also screen if there are other risk factors like childhood cancers, transplant of any organ, HIV infection, antidepressants, or chronic kidney disease. And again, if they do have hypercholesterolemia, it depends on the area, but usually cardiology, we're happy to manage that. If they don't, and you've got a family of myocardial infarction, I honestly think the family member's risk is very low. And that's just something to reassure, especially if you can ascertain some of those risk factors. So the next cause we're going into is aortic dissection, which is most common in patients above the age of 60. And again, high-risk factors are hypertension and atherosclerosis. There's also an association with smoking, which again correlates to atherosclerosis. But it's acute chest pain, BP difference between arms, and mediastinal aortic widening. Again, much more common in adults. If you're seeing it in the 60s, you're not seeing much of a family history. You're not worried as much. But again, as I said, it's a spectrum, especially at younger ages. Yeah, so they mentioned diabetes due to list of risk factors. And yeah, again, I need to look, meaning diabetes contributes to atherosclerosis. So yes, it's an absolute risk factor for dissection as well. But yeah, younger age group, and you're not seeing the risk factors, suspect aortopathies. And aortopathies are almost always, meaning they are congenital, they are genetic, they will need to be worked up. But again, this is where you come in and you can either expedite workup or help or speed things up. But yeah, Marfan syndrome, Ehlers-Danlos, bicuspid aortic valve, Turner syndrome. I'm going to talk more about Marfan's and bicuspid aortic valve because those have strong genetic associations. Regardless of cause, blood pressure control is important. It reduces the risk for aortic dissection, and whatever cause you're suspecting for any aortopathy, if there's a family history, better blood pressure control reduces the risk. A lot of bicuspid aortic valves, Marfan's, are under strict blood pressure control for that reason, to prevent dissection. So Marfan syndrome, it's an autosomal dominant disease. There are quite a few gene mutations. And again, I'm not going to gene mutations, but to know it's fibrillin. And the main increased risk factor for that is aortic dissection. So there are a lot of clinical features associated with Marfan syndrome. So this is the thumb sign, and it's basically if you put your thumb across your palm, it sticks all the way out. The wrist sign is if you wrap your thumb and your pinky finger around your wrist, it goes all the way around. Your thumb can go over your pinky finger. They often have arachnodactyly long, thin fingers. They often have characteristic faces, flat palpebra, a long, narrow forehead, as you can see with this family. They often have flat feet. They often have stray. They can have pectus carinatum or excavatum. And again, identifying these things is important. Marfan's eventually is a genetic diagnosis, but you can have a strong clinical suspicion. I will say I've seen patients with Marfan syndrome who look completely normal. But if you've got a family history of known Marfan syndrome, first-degree relatives absolutely should be checked. And in fact, if the family member is being followed by cardiology, we will make sure the family members are being checked. Again, what I'm helping here is identifying Marfan syndrome. And this is something there's an app for, and the quality didn't come out really well, but it's an app, or the Marfan Foundation has a diagnosis calculator where you can do a physical exam with this next to you. And we've talked about most of these signs, and you give a point. Usually 7 or more is, I shouldn't say diagnostic, but very high risk for Marfan's, and we are going to be sending genetic testing. So again, even though genetic testing isn't happening in the PCP office, your suspicion can be higher or lower based on your physical exam. And this isn't something you have to remember. I promise you, I don't remember it. I just opened this up and put the tallies in. And again, they've put increased arm span and height. That's the ratio is, meaning the wingspan over their height is 105, or they could have arachnodactyly isn't a strict criteria, but it's going to lead to wrist and thumb sign. And ocular lens dislocation is not very, but commonly associated with Marfan syndrome, and that can cause severe myopia. So, but yeah, if you have thoughts of Marfan syndrome, whether it's a family member who died suddenly of aortic dissection or someone brought it up, these are the exams you do, and to hopefully get an idea whether they have it or not. One of my friends asked me recently whether you would just refer to cardiology, and you would. And one reason is, one of the factors here is mitral valve prolapse, and that's an echo diagnosis. So one way or another, if there's suspicion for Marfan's, we will be getting an echo. We also, even if it's not Marfan's and there's a history of aortic dissection, we want to measure the aortic diameter. So like I said, this isn't a patient you're not going to refer just because you know it's Marfan, or even if it doesn't meet the criteria, but it gives you an idea with the urgency what you should think. If you've got a lot of these signs, you can go ahead and order the echo. Another interesting thing about this calculator is some of these things the pneumothorax, the dural ectasia, you're not going to see on exam. It's more whether you had clinical other tests like history of pneumothorax or an X-ray. I wouldn't even recommend like just doing head imaging just to figure out dural ectasia. That's something that can be planned in the longer run, but it's not something that's normally harmful to patients. But yeah, I did want to introduce you to the system score and identifying Marfan's patients because it is very useful and it helps, again, as I said, risk stratify. Talk about aortic dissection. This is the other major thing to look for in family members is a bicuspid aortic valve. Some family members will know if they had if their family members had a bicuspid aortic valve, some won't. But if they tell you, hey, my dad had a bicuspid aortic valve, whether it was a dissection or not, they need to be screened. There is, the numbers are varying depending on study, but at least, I mean, some said 10, but some said 30% of first degree family members will have bicuspid aortic valve, and we haven't identified the gene or the cause, but it's just been seen. Even if they don't have bicuspid aortic valve, they can still be at risk for an aortopathy and ultimately dissection. And again, we don't know the genes for this, but we've just known it to be true. So if you can ascertain that there's aortic dissection and the cause of bicuspid aortic valve, absolutely you can get an echo for the families. It's plus or minus whether you want to refer to cardiology before or after the echo. We don't, if the patient doesn't have a bicuspid aortic valve and the aorta measures normally on the echo, there are varying guidelines. Some say they could still have aortic issues 5-7 years later. Some say they don't need cardiology follow-up at all. Either way, if you were to refer them to cardiology, we would see them every 5 years. But the guidelines are a little disparate there. And another interesting thing about bicuspid aortic valve, it is the most common congenital heart disease. More than VSDs and ASDs, that is what we see. If you've got a suspicion whether you want to refer to cardiology or echo first, you can listen to them. Yeah, if you hear a click there's usually a click right before S2 and can have a murmur if there's some stenosis happening. Kids with bicuspid aortic valve don't often end up needing surgery around, as I said, 10 to 22, but it's much likelier as they grow older because it's an abnormal valve and takes damage over time. Yeah. And the last cause of, again, not last in the sense of exhaustive, but last major cause I'll be covering is arrhythmias. And at least 1/3 of sudden cardiac deaths in childhood. It's a little less in adulthood because their risk factors are not associated with structural issues. And these are, especially if you know it's cardiac, these are more likely due to arrhythmias than until proven otherwise. Inherited forms are channelopathies, which the most important are long QT syndrome, CPVT, catechular cholinergic polymorphic ventricular tachycardia, which is you go into VTAC during exercise or with activity, and Brugada syndrome. SVTs are fairly common in the pediatric population, and there are familial SVTs, but they don't necessarily have a strong genetic association. I'm saying again, if you're worried, it's not wrong to get an ECG. I have had referrals for family history of SVT, and if they don't have an abnormal ECG, I'm not necessarily working them up or even following them frequently. If there is a familial cause of SVT, again, I would hope as cardiologist or the cardiologist following the SVT, we'll be on top of it and ask the family members to be screened. But if we don't think there's a genetic association, if the cardiologist following whoever has the SVT does not think there's a genetic association, it doesn't need to be followed. Meaning you don't need to necessarily screen or refer the child to cardiology. One reason I haven't mentioned more about SVT is it doesn't normally lead to sudden cardiac death. It's painful, symptoms can be prolonged. Obviously, we want to treat it, but the channelopathies are more likely to cause sudden cardiac death, which is the other reason you don't need to go all out and just because there's a family history, keep monitoring. I can't promise the kid won't have a SVT. They're at the same risk as anyone else, but it's not something you need to excessively follow or get serial ECGs or anything like that. And so going over the common channelopathies, usually these are defects in ion channels, lots of genes, again, not going into those, but long QT syndrome. Going over, so there are 3 types of long QT syndrome, again, related to the genes. And it's just interesting knowing the types because when they cause sudden cardiac deaths or syndromes. The first patient I saw in Hawaii, a lot of family members had passed away while swimming. And so that's type 1. Type 2 is if you're startled or a loud auditory response. And type 3 is during sleep. Again, suspected QTC is more than 450 to 470 in males or greater than 460 to 480 in females. The reason I've given a range is because, again, there's no set value. If you take the lower number, you're going to get a few more false positives and you'll miss a few less diagnoses. If you take the higher, you could miss 1 or 2 diagnoses, but you could absolutely have normal males in the 470 millisecond. And QTC has to be measured manually. And this is just, I've shown this, and again, usually it's the cardiologist who will measure it manually. And the reason the machine can read it wrong is sometimes it measures the last pump as the end of the QT. And it can often give you an exaggerated, a machine read can often be exaggerated. I often say during my last year of residency, when I knew I wanted to go into cardiology, I was interpreting all the cardiology QT intervals for the residents. But yeah, you measure it for QTC is basically QT and it's a square root of the RR. And again, and QT, so the interval ends at the end of the slope, not at the last rise, not even if, it tapers out. It's when that slope hits it. And yeah, it's confirmed with genetic testing and a lot of these patients are on beta blockers. This is probably normal, but this, you can see there's just a huge gap. And even when you count for the bradycardia, I think the actual ECG, it measured 490 or 500. Quickly going into the other channelopathies, and this is, again, just because these ones are important. If you have a history like you don't know the cause of a sudden cardiac, you cannot ascertain, MI or dissection. If you get an ECG, if it's normal, doesn't mean everything's normal, but you can be reassured. But we want you to be able to look for these pathologic ones, which is again a call to cardiology saying, hey, this is grossly abnormal. We need you to see this maybe quicker than. But yeah, Brugada syndrome is ST elevation and right bundle branch block. So you can see that pattern as well as this abnormal ST, especially in these early leads. And there is for sudden cardiac death due to either VTAC or VF. And CPVT, the ECG may be normal at baseline. But when they exercise, it can be bidirectional VT. So it goes both up and down. And again, CPVT can have normal ECG at baseline, which is why you still refer people and we'll get screening tests based on the history. But in case you see it, that's what to think of. Okay. And I didn't know where to fit hypertrophic cardiomyopathy among all these deaths. I would say that a cause of death, hypertrophic cardiomyopathy is the leading cause of death in athletes. So if you hear of a sportsman who passed away, that is one of the things you should be thinking of. It's not uncommon at all. It's 1 in 500 adults. And again, it's commonly autosomal dominant, but several genes are involved. It can be recessive. And there are syndromes that present with hypertrophic cardiomyopathy. Most of them warrant an echo. Reason I put it after arrhythmias is the death can be due to, critical aortic obstruction, but arrhythmias are very common in hypertrophic cardiomyopathy as well. And again, if there's a family history of hypertrophic cardiomyopathy, then never wrong to get an echo. It can be negative, like a 6-year-old may not show those signs, but it's not wrong. It's what we would do as soon as we see them as well. And then we would decide on genetic testing. If the genetic testing is negative, they're home free. And exam-wise, this is one of the only ones I've talked about which will actually have a murmur, like arrhythmias won't, and even the MI or won't. And this is different from an innocent murmur. If you stand up, an innocent murmur is softer. And the hypertrophic, because it's flow inversely related to flow, it's higher. 90% have an abnormal ECG, but there can be some overlap with athletes. Some of the things you see are left ventricular hypertrophy, which athletes can have. Dagger-like Q waves, which are rarer in athletes. ST changes are also rarer in athletes. So those are things you're looking for. And echo is basically confirming the phenotypic diagnosis. And if an echo confirms it, you restrict sports participation. Just a quick line on congenital heart disease, because it's not usually sudden cardiac death, but I did say briefly talk about early cardiac death, and cyanotic congenital heart disease definitely is a cause. They're just at higher risk. VSTs, ASTs can live normal lives, especially if they're repaired, but a lot of cyanotic, they will have numerous interventions. They do have a shorter lifespan. And once you have a kid or any family member with that, there'll always be that anxiety, will another kid have it? And again, there is an increased risk, but there's no definitive relationship established. If we know, like if a cardiologist knows if there's a first degree relative with congenital heart disease, we do fetal echoes of all future siblings. So hopefully that should diagnose some right away, and you'll have an idea whether they need to be referred or not. If they didn't, you can again refer to a cardiologist, and we can evaluate them. That being said, if it comes out, when they're 3 or 4 years old and they say they had a cousin who needed it and they're playing around, never had blue spells, it's unlikely. 2 congenital heart diseases I'm touching on. Coronary artery anomalies, I said most don't cause sudden death, but they can. Again, there's no known heritable cause, so it's not something you need to have a high suspicion of, even if it's a family member, but it's something we'll evaluate for. They can come from the pulmonary artery, they can come from, they can go between the muscles, so when the heart squeezes, it can reduce coronary supply, or they could just not develop. And dilated cardiomyopathy can also cause early death, and that's heart failure, and that's genetic basis. So again, family member has dilated cardiomyopathy, that is a reason to refer, and we're probably going to be doing. And again, this is something the cardiologist may have acted on already because they're following the family member. But if you find it's been missed, that's a reason to refer. And that's most of what I wanted to go over. I didn't realize I went a little over time. I'm sorry.
No, not at all. You're honestly very, very perfectly timed. There are a few, there was a little bit back and forth in the chat about various athletes that have passed away. And a few questions that did come up. One was if you happen to know the most common causes of the recent cardiac arrests of high-profile athletes.
Yeah, so hypertrophic cardiomyopathy is common. One of these, I'm forgetting, the football player was probably had commotio cordis, which can happen to anyone. It's not genetic, it's scary, but if you're struck in the chest at the exact wrong time, it can push you to VTAC. And that's it's in the T wave interval, and it just triggers things the wrong way. I'm forgetting the football player's name. And
I generally don't remember any of their names either. I
Yeah.
can help you.
Yeah, and I'm trying to think of LeBron James. I think we were suspecting an arrhythmia. I don't know how much has come out. Oh,
His son, yeah.
yeah, that was it. Hamlin was commercial cordis. And yeah, so, and I'm forgetting LeBron, but I think they're suspecting an arrhythmia. I don't think his was commercial cordis. Yeah, and Damar Hamlin, thanks. He was the one. He was definitely
The one.
Yeah. So I see two more I may have missed. Cardia Mobile is being used in, we like it a lot more than Apple Watches. It's pretty quick. In a week ago, I actually took a kid who measured it on Cardia Mobile and it was accurate. The reason it's not, meaning it's not necessarily replacing a Holter. Firstly, it's less leads. And secondly, it's just more from a legal perspective, how you can send them. That's a very institution dependent thing. I'm sure some institutions, if they're okay with, or they've found a way to upload it on my chart, they're using it as absolute acceptable. So it's pretty accurate, it's pretty reliable. And for those who don't know, Cardia Mobile is basically, it's a kind of an ECG which costs $120-$150, so if families can afford it. It's not covered by insurance, as it's not a accurate diagnostic test called a diagnostic test yet, but you put it on your leg, you put one finger on both sides of that cardia, and kind of acts like a 3-lead ECG. And so it is pretty, so it's useful for, I trust them. I think they give good info. It's more useful than the Apple Watch, but it can't be used as a diagnostic test yet. At least the world hasn't got to that. Then the question was congestive heart failure with an ejection fraction. So not necessarily congestive heart failure, but I know hypertrophic cardiomyopathy with a decreased ejection fraction, you're more likely to place a implantable cardioverter. You're not going to place a implantable cardioverter for any, like if you see an echo and you see a CHF for 35, that's not an automatic injection. In hypertrophic, it can be, but if you're seeing depressed function, again, needs to be worked up. You want to be on afterload, and you're in high risk in certain scenarios. Some of these kids, what we do is they're on home milrinone therapy, and we're placing them because milrinone, again, then you're increasing the risk. So, but to the best of my knowledge, isolated ejection fraction of 35%. I can say at least I've got congenital heart kids who have far more risk factors and chronically live at 30% and don't have a ICD. I'm sorry, I don't know what WF stands for.
I'll go ahead and run the poll.
Yes, I wasn't sure what the WF stands for either. I'm so sorry. Oh, no worries. Yes, thank you. Thank you, Summer. In the meantime, we can go over the questions. Perfect.
Okay. So, do you want me to just discuss the questions and the answers and why?
No, we'll give them a few minutes.
Okay, yeah, I just want.
Thank you. And then we can discuss them.
Summer, I don't have any questions. Can you hear me, Summer?
Yes, I hear you. You can't, can anyone else see them?
I can see them. my end.
Renata, did I make you a co-host again by accident? No. I send them to you separately, Renata. I'll email them to you.
Oh no, more people who don't see the questions.
So strange.
Are you getting responses from people, from other people?
Yep, about 50%.
Yeah, maybe if everyone who can't see the questions can just raise their hand or note it in the chat, that way Summer can send it out to you via email.
That is so weird.
It happened. It's kind of a new problem that's been happening, right?
Yeah. I know it happened to Renata once, but that was my fault. I accidentally made her a co-host.
She was co-host, right? I remember that. Okay. We'll have to look into it.
Yeah. It was acting funny this morning. Zoom was acting funny this morning when I had meetings, but I don't know. Sorry. Glynis, I will send it to you as well. You'll probably hear the answers by the time you get my email, but as long as we have it down. Okay, and then I think we can go over the questions. I'll end the poll.
Okay. So, yeah, the first question is, one of your patients had 2 family members who died at the age of 30, one in their sleep, one while swimming. What initial testing will you perform? And the answer is ECG. I think in their sleep and swimming, I'm trying to, and that was in general, like ECG should be ideally the first test as we went over for most sudden cardiac death, but here I'm hinting towards long QT, which is absolutely genetic, and you may, other than just ruling stuff out, you may actually find something. Then you have a 15-year-old girl with Turner syndrome. She is healthy. Echo shows a bicuspid aortic valve with mild ascending aorta dilation. What is she at increased risk for as compared to the general population? And her main one is aortic dissection due to both the bicuspid aortic valve and her aorta dilation. Both are common things. Turner syndrome can also have coarctation of the aorta. That's a common association. But in this case, I was going over the bicuspid aortic valve increases the risk, and especially the ascending aorta dilation does. I will say no one with mild dilation is going to have it, so I don't want to fool you. If you see that on an echo report, they're not at immediate risk. You have to have pretty severe dilation. But as I said, over time, that's what she's at risk for, and we would want to control her blood pressure. Which of these is not a clinical finding from Marfan syndrome? I wanted to change. I know the world or the testing world is moving away from not questions. So I felt this is a little unfair because the Marfan syndrome has reduced extension of elbows. So when you go all the way, they can't go all the way. They usually always, and again, not all of them. In fact, that's one of the less common ones. But that's the others you can all see. The others, in fact, are fairly common. And which of the following ECG findings can be seen in hypertrophic cardiomyopathy? And it's the deep tag or Q waves, which again, no single thing is diagnostic. That's the echo and the genetic testing. But deep dagger Q waves are pretty likely. Yeah, LVH, as I said, can fool you again. If you do see LVH, absolutely, we can get an echo to confirm. But the others are, none of them are specific for, they don't really mean much in this. Prolonged PR interval can be seen with rheumatic heart disease, which we see plenty of in Hawaii. QRS inversion was just, I was kind of hinting to with the CPVT, but you're not going to see that with, and right axis deviation. They'll probably have left ventricular hypertrophy and can have left axis deviation, but the deep dagger Q waves is something that can stick out. Okay, I think those are my questions. And if anyone has any more questions, I'm happy to answer.
I don't see any more questions in the chat right now, and you are actually absolutely perfectly timed with 10 seconds to go until the hour is up. So if there are no further questions, I want to say thank you so much for coming and presenting. It was really good to seeing you. We're very, very excited for you to come back to Hawaii and work here as a specialist. And thank you everyone for joining. The next session is going to be on September 6th with Dr. Lynch. He's going to be doing an update on concussion management based on the 2023 Amsterdam Concussion Statement. Very exciting for that one, actually. I'm going to have to join, even though it'll be Maya's turn to facilitate. So yes, thank you, everyone. I'm seeing lots of thank yous and excellent presentations in the chat for you, Jay. So have a great rest of your day, everyone, and I will see you all next week.
Everybody.
Thanks, everyone. I hope
Bye,
it was
thank you.